Good afternoon, everyone. We're going to get started in a few minutes. We're just uploading a new slide deck, so I'll be with you in a second. Make sure that you have, when you came in, that you have a copy of the exam and the evaluation for the program. Both forms need to be turned in, as well as you need to be registered at the front desk in order to get credit. So just make sure that you take care of that so you can get the appropriate credit for it, okay? We'll be with you in a minute. All right, we're ready to get started. Good afternoon, everyone. Welcome to the Core REMS training program. My name is Linda Caston, and I work for Pain Management Services at Intermountain Healthcare. This afternoon, we're going to have an educational activity that is now supported by the REMS program and multiple companies. This program is intended to be fully compliant with the opioid analgesic REMS education requirements that are issued by the U.S. Food and Drug Administration and is approved by the state of Utah for licensure. I'd like to introduce Dr. Tim Houden, Medical Director for Intermountain Healthcare Pain Services and Course Director for the CORE program today. He has specialized in pain management since 1993 and has served as the Medical Director for Intermountain Healthcare since 2005. Under his direction, the functional restoration team has produced 4 care process models for chronic pain and provided additional clinical guidelines and education for primary care providers. He is currently the president of the Utah Academy of Pain Medicine and is an advisor for the UMA Opioid Task Force. He is also a diplomat with the American Board of Pain Medicine and is board certified with the American Board of Anesthesia. with a subspecialty in pain management. Dr. Houden is founder and medical director for the Utah Spine Care, a multidisciplinary team pain clinic, and a master's level instructor for Spinal Intervention Society. Dr. Houden practices in pain management at the Utah Spine Care and also provides OB anesthesia at the McKay Hospital in Ogden, Utah. He received his medical training at the Medical College of Wisconsin and has completed his residency at the University of Utah. Let's welcome Dr. Houden.
So we're working on this technical glitch. I'll tell you a little bit about myself, aside from what you just heard. Like a lot of you in the audience, when I was in college, I was studying to be a medical student, and I was trying to get A's, and I was pretty good at getting A's, and I did it in the hard courses just like the rest of you, and I worked hard. And one summer I decided to do an easy class. So one summer in college I decided to do an easy class, make it, get an easy A. So I took Public Speaking 101. I did not get an A. I did not get a B. I did not get a C. And I did not fail the course. So, being a typical type A personality, I went to that professor and I said, "Doctor, I didn't get an A. It's the first time I never got an A, and you ruined me. You ruined my chances for medical school. You've ruined my entire life. What can I do?" She goes, "Well, first of all, you're the one that ruined your life. I don't think this is going to ruin your life. I only have one bit of advice. I'm not going to change your grade, but whatever you do, never, ever, ever go into any kind of field that involves any kind of public speaking whatsoever." So it was with that warning, and now that we've got the glitch fixed. So this is a REMS program. CORE stands for Collaboration of Risk Evaluation and Mitigation Strategies. REMS was an FDA-mandated course for opioid education. This came in 2012 when the opioid crisis was very much being recognized. The FDA mandated that pharmaceutical companies fund education. The grants come from the pharmaceutical companies, and that's why this course is free to you. If you want a list of who contributed, we have that available for you. 11 organizations came together to build this program. The faculty that built this program is in front of you. None of these people had conflicts of interest. They continue to update this program to keep it REMS certified so that it's FDA approved. There are 3 approvals that you need. The reason why you're here is because DOPPLS tells you have to get your 3.5 hours of education. It's now Utah legislation that you have to get 3.5 hours of education, and now it's FDA mandated that you have to get 3.5 hours of education. These people make sure that we give you the correct education. We will be using brand names. That is not to endorse a product. That is for educational purposes. So why we are here? Well, I know why you're here. You have to be here because nobody really wants to come down on Friday afternoon and listen to me talk, especially my speech teacher. We're here because we have an opioid epidemic. It started in 1990 when many of you remember the 5th vital sign. We were under-treating pain, and there was a push to push more pain management, more drugs. And as we prescribed more medications, we started seeing more opioid deaths and more treatment admissions with opioids. This got worse in the last 8 years. There was a huge spike in opioid-related deaths. It was mostly related to prescription opioids, but what we also noticed was there was an increased spike in heroin-associated deaths. And the last couple years, it is now fentanyl, street fentanyl, illegal fentanyl. It's being spiked in drugs that look like the drugs that the patients want. They counterfeit the medications. They lace it in heroin. They lace it in a lot of the drugs that they're selling. It's a cheaper drug than natural opioids, and so it is currently one of the bigger problems. It's more so out east than it is here, but it's starting to show up here in Utah. So the fentanyl opioid deaths has increased 540%. Again, the problem is it's a street drug, and it has two issues. It's not only does it have respiratory depression, but it also causes a rigid chest wall syndrome, which all opioids can do, but especially fentanyl. Utah is one of the worst states in the country for opioid prescriptions and opioid prescription deaths. We were the fourth worst. Now I think we're the sixth or seventh. I think we improved a little bit. We're still at the bottom. We are still overprescribers. We had 456 deaths alone in 2017. Most of the deaths in Utah are related to prescription medications. So they're coming from us, the prescribers. Here's the national average of opioid-related deaths. Here's Utah's opioid-related deaths. So as I said earlier, it started out with we were underprescribing and undertreating pain. Then the pendulum swung to overprescribing and overtreating pain and giving out too many pills. Too many pills on the shelves available to access from family members, kids, and it's those number of pills that we're trying to reduce as well as better control of our opioid management. So our goal of our course is appropriate prescribing with adequate analgesia. So our goal today is help you identify the benefits and the risks of opioids. You all know the risks. I don't need to list down the risk of opioids. And you all know the benefits. Our goal is to make sure that the benefits outweigh the risks on every patient and every individual patient. Here's a great slide. 90% of people that misuse opioids, the drugs that they misuse, are prescription drugs. Either the patient you prescribed them to, 30%, 36% we prescribe to that patient, but they don't take them appropriately, or 54% as our pills that we prescribe go to the street. They get stolen, they get sold, so that means we're giving out too many pills and they're going someplace they're not supposed to be. So of course the federal government got involved, multiple organizations got involved with the opioid crisis. Last year, Donald Trump, the Democrats, and the Republicans all agreed on one thing, and that was the opioid crisis bill. The FDA, as I mentioned earlier, stepped in 2012. They mandated this course. This is the first time you actually get CME credit for a REMS certified course. Our core statement. Oh, good, I have it right here, so I don't have to keep looking backwards. Misuse, abuse, diversion, addiction, and overdose of opioids has created a serious public health epidemic in the U.S. When prescribed well and used as prescribed, opioids can be valuable tools for effective treatment of pain. This course is not to discourage you from prescribing opioids, but to help you prescribe opioids appropriately. The learning objectives: accurately assess patients for an opioid trial, establish realistic goals for pain management and restoration of function. The key thing that you'll learn today is we want to emphasize function more so than reduction of the VAS score. Initiate opioid treatments, initially with immediate release opioids, and then when appropriate, intervene with long-acting opioids. Monitor and reevaluate on a regular basis. Counsel the patients and caregivers about the use, misuse, abuse, diversions, the risks. This is now actually a state law. Whoever prescribes the medication has to counsel the patient, and it has to be charted in your notes. Educate patients about safe storage and disposal of opioids, and demonstrate the knowledge of the opioids that you're prescribing. With you reducing the number of pills that you prescribe, and with you reducing to an appropriate level of medication for the patients, you can make a big difference in the opioid crisis. You should have received questions and that you'll be filling out in a form. You need to fill that out. That's for two reasons why you need to fill it out. One, the FDA uses it it doesn't matter if you get the questions right or wrong. They use it as indicators on how many people are taking REMS certified courses. More importantly, it's how you get your CME credits, is filling out this form. So fill it out and turn it in at the end. We will be going over all the questions for discussions at the end. I'd like to introduce our next speaker. Gaylinn is the Advanced Practice Director for Hospital Medicine at Intermountain. She's an adult geriatric nurse practitioner who used to do palliative and hospice care and intensive care. She then went to neurosurgery at the university where she moved to Tosh, where she's the director of the acute pain service for Tosh. Gaylinn? Once again. If you guys don't mind, we would love to fly through this lecture, all lectures as quick as possible. Try to get out here a little early and not take any breaks. And I think we can do it a lot quicker than anticipated. We just have to get the right information out. So go to the bathroom on your own. We won't take breaks. We're going to try to fly through it, and then we'll hold a discussion section after our break for those of you that want to discuss more.
Okay. Okay, so my section is obviously on pain. And this slide, we're going to talk about the neuropsychobiology of pain. And how many of you don't have to raise your hands, but how many of you have ever had the pleasure of stepping on a Lego? Or for those of you that have been more experienced in life, a jack or a nail, right? So you've had that fun, wonderful pleasure of having that nerve that runs from your toe, runs up to your spine, and then goes to your brain, right? Well, we've all had that wonderful, beautiful experience. And so on this next slide, we're going to talk about some of the sites in the brain that deal with that sensation of pain. So on this image, we look at the neurobiology of what's happening when we take opioids. In the periaqueducal gray area, it's an important center in the pain inhibition. And this is the actual area where we want the pain opioid or the opioid to go. Sorry, you know what? I would have failed speaking. I don't know what it is, but I am so afraid you guys are going to come up here and bite me or something. So I apologize if I kind of stumble over my own words. The nucleus accumbens, it also plays a central role in the reward circuit, and it's where euphoria is perceived. It operates on two essential neurotransmitters, the dopamine, which promotes desire, and also serotonin, which effects include satiety and inhibition. This is where all drugs increase the production of dopamine in this area while reducing that of the serotonin. And this area, however, does not work alone, and it works closely with other centers involved in the mechanisms of pleasure, in particular the VTA. The VTA is also influenced by endorphins, whose receptors are targeted by opioid drugs such as heroin and morphine. Sorry, I get so scared up here, I had to write notes. Another structure that's involved in the pleasure mechanism is the prefrontal cortex. And this has a role in planning and motivating action, and that's been well established. The prefrontal cortex is a significant relay in the reward circuit, and then also modulated by dopamine. The amygdala plays a role in stressful feelings like anxiety, the irritability, the unease, which when somebody gets that high, it also motivates that person to go out and seek more drugs when it's gone, right? Next slide. So this slide gets really busy. So we're looking here, what is the psychological stimulants? And so we look at here, you've got nociceptive and the neuropathic pain. So we know what the difference is between the neuropathic pain. You've got peripheral neuropathy and post-herpetic neuralgia. How many of you had patients come in with that post-neuralgia pain? Pretty painful, right? Yeah. And then you've got thalamic injury, central hypersensitization. Now, when I was in the ICU, we had patients that came in with these horrendous trauma injuries and things like that. And so on the nociceptive pain, you have tissue injury, mechanical abnormalities. I remember watching these basketball games where you see some of these basketball players, they make a layup and then they come down and then you see their ankles twist. It makes me kind of cringe. Inflammation, tissue invasion, and tissue injury. A lot of you guys, if you can't read this or it's really busy, you're going to get a copy of this slide, so don't be too worried about not being able to read all of this. A lot of patients, you have to look at the whole realm of what's playing into a patient's pain. So you have this biopsychosocial atmosphere that's going on, so you have to really look at what's going on physiologically, physically, psychologically, spiritual, social, a lot of things that are playing into this. And you want to make sure that you're addressing these unrealistic fears that these patients may be having with all of their pain. On this slide, it's talking about chronic pain. In patients with chronic pain, they're often at risk for developing further complications, including altered mental statuses and physical dysfunction. Also, the intensity of chronic pain was found to be statistically significant predictor of hypertension, independent of demographic predictors such as age, sex, race, and family history. And numerous studies indicate that patients with chronic pain are more likely to develop psychological disorders than those without chronic pain. It has been associated with higher rates of major depressive disorders, suicidal ideation, and suicidal attempts. You can get impaired memory, hypertension, sexual dysfunction, and obviously the quality of life is impaired. So on this slide here, we're talking about different multimodal pain management. So you have number one, which is the cognitive behavioral therapy, behavioral modification, meditation, cognitive restructuring. And then you have the physical components. So making sure that your patients understand that exercise is super important. Acupuncture, movement therapies, manual treatments. Then there's always the interventional treatments. There's the nerve blocks. There's the steroid injections, stimulators, trigger point injections. And then there's, last but not least, the pharmacotherapies. So starting off with the NSAIDs, using antidepressants. Opioids are kind of like your last step. And then the cannabinoids, anticonvulsants, and topicals. And then we just have in here cultivating well-being, reducing pain, restoring function and quality of life. So these are just pearls for practice, and you want to make sure that you're discussing these with your patients and making sure that they understand the neurophysiology of pain, and then making sure that your patients understand and that their concerns are really validated, and that the pain has a biological, psychological, social, and spiritual components to it, and it's just not all, up in their head. This next slide. So what would you guys say this is? Is it misuse or abuse? Your patient requests an early refill for the second time in 6 months. Your patient took extra medications for a headache and again for a toothache. Prescription is for lower back pain. What would you think this is? A misuse or abuse situation? Okay. All right. Evaluate potential misuse. Confirm the patient's understanding confirm patient's understanding for each medication dosage, time of day, and maximum daily dose. Ask him or her to repeat these instructions back to you, and avoid clinical terms such as PRN. Review treatment goals and expectations, and select and document a therapy plan that is compatible with a patient's individual needs, is safe, effective, and balanced. Screen for a risk for current opioid misuse measures, and if indicated, refer to addiction specialists for treatment. Dr. Houden, I think we are going to really go through this pretty quick. Okay, next section is on assessment. Super, super important, right? We all know how to document, and we have been ingrained in our education on the importance of documenting. Okay, so what are obviously the things that we want to chart? We want the description of it, right? We want the location, the intensity, the quality, the onset, how long does it happen? What are the patterns? What makes it better? What makes it worse? What are the effects? Can you go for your walks? Things like that. What are the things that a patient has tried to help relieve that pain, both pharmacological and non-pharmacological? Is the patient, what have they done for things for pain in the past? What are their current uses? If you want to make sure that you have a dosage, and I'll be honest with you, and I'm sure you guys are all very well aware of this, patients sometimes are not very forthcoming in what they currently are using and what they have used in the past. I know a lot of times when I'm doing a history and physical, especially for surgery, you know, we ask them about illicit drug use, and you'll get the young kids or some that are not that young, and they will say, well, why do you need to know my illicit drug use? And I'm like, look, I'm not your preacher, your pastor, I'm not a cop, I don't really care about it, but when it comes to surgery, it can interact with anesthesia. And I use the example of, you know what, I have a cute little 91-year-old lady who smokes marijuana a couple times a day. Great for her, but I don't really care. I just need to know for interactions with for the anesthesia. So also looking for the effectiveness. What are you currently taking? Does it work for you? So the past medical history, extremely important. So pain patients are often prescribed multiple medications, right? You have to be aware of what mixes with what their current medications are. We all know we've had these patients that come in with a seizure disorder, and hopefully you're aware of what opioids can potentiate or affect these medications. They can overlap with toxicities, they can decrease the functions of those medications, so it's really important to take a look at what their medications are. If you have a chronic kidney disease patient, what can that potentiate, things like that. Also the illnesses, HIV, STIs, hepatitis, all of those can interact and really affect those opioids. So those are all really important to have there. If not, your pharmacist is extremely invaluable to use, and use them as a resource. Okay. So also part of this is looking at risk factors. I don't know, like in a clinic setting, or even for doing like a pre-op physical, or if in your, you know, you have a patient that's hospitalized, you're looking at more than just the patient. You're looking for nonverbal cues for a lot of this risk for opioid use, misuse, and abuse. When I was in hospice and palliative care, we had patients, family members that would take medications. We would have to use lock boxes and things like that. And to have to keep the patient safe, you know, it's not, it's what you have to do sometimes. So you have to look at the risk factors for the controlled medications, alcohol and tobacco. Again, a lot of patients aren't forthcoming, unfortunately, and so you can get a lot of withdrawals that play into that. History of sexual abuse, family history of substance abuse and psychiatric disorders. And then again, age plays a big, important part into this. Social history, so things like, are they employed? What are their cultural, what's their cultural background? What's their social network? What's their marital background? Things like that. That all takes into account. And then, of course, the physical exam. Very important because, and I don't want to, more times than not, have I seen people, they're very tricky. When it comes to injecting illegal substances, underneath nail beds, between toes, things like that. So you just have to be very thorough in your exam. I've seen patients come in with fentanyl patches on and they deny that they're on any medication. So that's where really diving in and trying to get a really thorough history on a patient is really important. Later in this lecture, using the database, Utah database is extremely important to try and help you decipher more information. You're going to be looking for any objective data, subjective data, and then really using any type of diagnostic tools that you can to help give you that broader picture that you might need to help these patients. Vital signs, the neurologic exam, and of course, do the full musculoskeletal exam. And documentation is key, right? So on here, there are quite a few tools that are available. And I'm not sure what you guys have available in your EMRs or if you do paper charting or things like that. So I printed off a couple of different copies, the ORT, and they're available over here on this table to take a look to whatever, because I know when I've sat through here, through this lecture, I didn't know what some of these tools looked like. So these are just some risk assessment tools that you can use. This is for when you look at considering patients for long-term opioid therapy. This ORT is an opioid risk tool, very short. If you guys want to look at this one, it's over here. I know you in the back, you can't see this, but I've made some copies for you. Also, the SOAP, there are 3 different SOAP forms. The SOAP it's a screener. There's a short version, a very short 5-question, 14-question, 24-question. My preference is shorter the better. So I've only made 2 copies. You've got the long version, 14. It has some instructions, and I don't recommend any one or your preference. I just brought them so you can see them. And then the SOAP, which is just the simple 5-question one. Again, they're all over there. The DIRE, which is the Diagnosis, Intractability, Risk, and Efficiency Efficacy Score, looks something like this. And then the Characterize Misuse Once Opioid Treatment Begins. I think I left that bunch at home, so you guys get off lucky on that one. And then these ones, the ones that I have next, they're not really specific to the pain population. They go over things like alcohol and things like this. So this next one is the CAGE. Again, very simple, short, sweet. This one is the DAST, which stands for Drug Abuse Screening. Very short, sweet. This one is This one is the Cybert. So again, alcohol, sweet. So please feel free to just take a look at them, take a copy if you want. Also on the presentation, it does have the opioid risk tool. Goes over that, just a brief overview of this. And then some brief instructions on how this SOAP is administered. So we know that opioids, pain, and addiction all kind of intermingle, right? That's why we're here. That's why we're learning about it. So really, what are the risks for my patients? Well, besides the hypercapnic respiratory failure and the hypoxemic respiratory failure and cardiac pulmonary arrest and things like that, you have the addiction, you have recognizing the patient's needs and the pattern shift with age, and you have the gamut of all of these risks, and you really want to understand what those risks are for the patients. So pain and addiction. So we have the 5 A's for pain. So analgesia, the extent to which there has been pain reduction to an acceptable level for the patient. And activities, to the extent to which work, play, and socialization are either a positive or a negative impacted by pain or analgesic regimen. The aberrant behavior is evidence for drug addiction or drug diversion. The adverse effects, extent to which AEs or adverse effects of analgesic regimen are minimized. And then the effect, extent to which mood and sleep have been positive or negatively impacted by pain or analgesic regimen. And then you have the addiction, the 5 C's, the loss of control, the compulsive use, the craving of the drugs, the continued use despite the consequences, and then the chronic problem. So the risk and pain assessment toolbox, pretty self-explanatory here. You look at things like this, and you have the pain assessment tool. So you look at the BPI, the functional assessment. So there's the geriatric assessment, the SF-36, pain intensity, the enjoyment of general activities in life. We pretty much all are pretty well versed, I would at least hope you are, in the PHQ-9 and the GAD-7. I also do have copies of those if you're interested, if you haven't seen them, which I'm sure you are. Those are also over there. And then using the risk assessment toolbox, the PDM-P and the UDT, and then using your risk assessment tools, again, those are over there. But invaluable when you're looking at those risks, utilize those tools that have been put out there to really minimize those risks for those patients. So when do we consider a trial of an opioid? So really when the benefits might outweigh the risks, and then when patients have failed to respond to non-opioid and non-drug interventions, and when the pain is hitting that moderate to severe range, and then also when you want to initiate a trial of immediate release opioids, you definitely don't want to go into the extended release opioids at the first. Okay, here we go. This is just a summary slide. So you have a 60-year-old with chronic disabling osteoarthritis pain. He has been on non-opioid therapies and they're non-effective. He has no psychiatric or medical comorbidities or personal family drug history problems. He has high potential benefits relative to potential risks, and he could prescribe opioids to this patient in most settings with routine monitoring. Do you think he would be a good candidate? Yeah, okay. So the next scenario, you have a 30-year-old with fibromyalgia and recent alcohol use disorder. High potential risk relative to benefits. Opioid therapy, not first line for fibromyalgia. It requires intensive structure, monitoring, and management by clinician with expertise in both addiction and pain. Not a good candidate, right? So, according to the CDC in 2016, these are the guidelines for initiating opioids. You obviously want to start with immediate release. You want to start with the lowest range and then kind of go from there. So start low, go slow. You want to be very cautious with any dosage, but particularly when increasing dosages to greater or equal to 50 morphine milligrams equivalents, and carefully justify a dosage or a decision to titrate dosages to greater or equal to 90 morphine milliequivalents a day. So for acute pain, prescribe the lowest effective dose of IRs, no more than needed. Reevaluate the risks and the benefits within 1 to 4 weeks. or dose escalations and make sure you're documenting all that. Reevaluate risk and benefits every 3 months. If benefits do not outweigh harms, optimize other therapies, work to taper and discontinue. And then down here, you'll see that the link to the guideline is right there. So this guideline is not covered as far as cancer pain, hospice, or palliative care. That's kind of a different realm, different world. Informed consent. Very important to protect you and the patient. When initiating the trial of the opioid analgesic therapy, confirm patient's understanding of the informed consent. 1, to establish the analgesic and functional goals of the treatment, and the expectations, the potential risks, and the alternatives to the opioids. And how do you manage? What does a patient do when there's common adverse effects? Well, we all know that it's lovely because you get that wonderful constipation, you get the nausea, you get the itching. There's always the risks, abuse, the addiction, respiratory depression, and overdose. And then obviously you have the adverse effects with long-term therapy, the hyperanagesia, the low testosterone, irregular menses, and sexual dysfunction. There is, again, very generic, but over on this side, I had copies of just very generic PPAs and informed consents. So the patient-prescriber agreement, this is a document that's signed by both you and by the patient. And again, it's to clarify their treatment and to their plan, their goals, to have the patient and the patient's family understand everything that's going on with the whole patient's treatment plan and what to expect. It assists the patient in their education, discuss medication safe handling and the storage of the medication, the disposal. I'm glad to see that a lot of the pharmacies now are starting to do a lot more of those take-back boxes and things like that. I don't know about you, but I don't regularly visit a police station. And then also to document patient and prescriber responsibilities. It also reinforces expectations for appropriate and safe opioid use. So again, it's really important to go onto the Utah website and make sure that there's only one prescriber that's prescribing these pain medications. And consider really only one pharmacy that's dispensing these medications. You don't want to have these patients store these medications in an unsafe location where you don't want to be the drug dealer for your grandkids, right? You want to make sure that they are locked away, that they are not somewhere where your grandkids, if you have older grandkids, their friends could come over and take them. You want to make sure that they are given instructions on where to safely dispose of those medications, and make sure that the prescribers are notified in the event resulting in pain medication prescriptions. And then any kind of education on following up and then monitoring. Random UDTs and pill counts, that's all going to be part of it. What are the expectations for refills? Identify any behaviors for discontinuing the pain medications, things like that, and having an exit strategy, making sure that that patient understands that. Routinely monitoring the patient for adherence to the treatment plan. Things that would throw a red flag in that the patient may be misusing the medications. Recognizing and documenting aberrant drug-related behavior. In addition to patient self-report, also use the state website, your urine drug tox screens, positive for non-prescribed drugs, positive for illicit substances, negative for prescribed opioids. Family member and caregiver interviews, very important. Monitoring tools such as the COM, the PDT, PMQ, and the PDUQ, and medication reconciliation. So making sure that that patient knows that you have to bring in your prescription bottles for those counts. And making sure that you are actually addressing those aberrant drug-related behaviors. Behavior outside the boundaries of agreed on treatment plans are grounds that you can actually stop treating that patient. So you can look at unsanctioned dose escalations or other non-compliance with therapy on 1 or 2 occasions, unapproved use of the drug to treat other symptoms. This goes back to that toothache, backache kind of a thing. Openly acquiring similar drugs from other sources, multiple dose escalations or other non-compliance with therapy despite warnings, prescription forgery, and obtaining prescription drugs from non-medical sources. And so any of those behaviors can merit investigations, and you need to proceed with caution. So again, make sure you are documenting. You want a CYA, and make sure that you are documenting your test results and everything, that the patient is aware of this. You want to make sure that you are protecting yourself. And so the last thing, pearls for practice on here is you want to make sure that you are conducting a comprehensive and pain-focused history and physical. Make sure you're obtaining all of that objective and subjective information. And you want to trust your patients, but kind of keep in the back of your mind that sometimes they may not be forthcoming. Assess for risk and abuse and for mental health issues. Determine if a therapeutic trial is really appropriate for the patient, and establish realistic goals for pain management and function, and document everything. So here is a challenge, the delayed surgery. Red flag. Patient may be stalling to continue an opioid regimen. Ms. Jones says she needs opioids to manage her pain until she can have surgery. She reports continued delays in getting the surgery. You phone the surgeon and discover that no date has been set and that she has canceled several appointments. You set a time limit and expectations, offer a non-pharmacological method and non-opioid interventions for pain management. Communicate with a surgeon and advise patient to make appointment with surgeon for discussion of treatment plan. Dr. Houden. Thanks for not coming up and biting me.
Thank you, Gaylinn. Our next speaker is Robin Ockey. I'm not going to read his bio right out to you. Instead, I'm going to tell you that he should not be wearing a suit coat. He should be wearing a cape. He is the medical management expert of Utah. He joined our functional restoration chronic pain team at Intermountain Healthcare several years ago, and we quickly realized that he was by far the star knowledge person for long-acting opioids, short-acting opioids, and he's become our state expert on opioids and medication management. This is Robin Ockey.
He asked me if I'd come up really quick and make this announcement so he didn't have to. We have a representative here from Weber Human Services, and they are offering a scholarship that would pay for your entire conference fee if you are from Weber County or Morgan County. All you would have to do is come back. We have something you can sign up, and we will send that information over to her, and she will basically send you a check for the cost of your tuition for this week. So if you're interested in that and you're from Morgan County or Weber County, come back and talk to me. So, back to you.
All right, so we're going to start by talking about some of the side effects of opioids. And of course, the one that deserves the most emphasis is that very top side effect, which of course is respiratory depression, because it's what kills people. And I think we need to always remember that risk. You know, it's interesting, the thing about respiratory depression is that it's a dose-dependent phenomenon. Back in 2010 and 2011, there were two different studies, one by Amy Bonert and the other by Katie Dunn, one in 10,000 patients and the other in 111,000 patients, that clearly showed that this was a dose-dependent issue. Prior to that, a lot of people thought, you know, people get tolerant to a certain dose. Patients come in all the time, I'm sure, to your practices and say, but doc, you know, I've been on this dose for 20 years. What are you talking about? But we know clearly that despite the fact that people are on doses for a long time, that the risk of respiratory depression is proportional to dose. And I think that that's critical. And superimposed on that is the fact that here in Utah, we prescribe high doses. And that's a problem. You know, if we look at the national data, some that Tim showed, it's kind of interesting. In Utah, the number of deaths due to heroin and illicit fentanyl is going up, but it's nothing like the national average. Our average is much lower than the national average. Our big problem is prescription opioids. And if you look at number of prescriptions that are greater than 90 milligrams morphine equivalent per 100, the rate of prescribing those prescriptions, there's only one state worse than us, and that's Delaware. We are and that's out of 51, that's the 50 states plus the District of Columbia. And we know from good data that if you're on more than 100 milligrams morphine equivalent, your risk of a serious opioid-induced respiratory depressant event, either death or hospitalization, is about 58 times the risk of a chronic pain patient who's not on an opioid. So that, and it gets higher as you go up dose-wise. So the bottom line is we need to always remember that respiratory depression. And we should also remember the fact that dose plays a role in that. And we need to be monitoring for that and educating and giving our patients informed consent about that issue. So opioid-induced constipation is the most common side effect, of course. It's not the one that typically kills people, although I suppose bowel obstruction can be pretty dangerous, but it's respiratory depression that's number one. Other issues, sedation, cognitive side effects, falls, fractures. I know that we often don't think about fractures as a side effect from opioid prescribing, but it's interesting that that's also a dose-dependent side effect. The higher the dose, the more likely a fracture. That's also true for motor vehicle crashes, by the way. The higher the dose, the more likely a motor vehicle crash. Sweating, hypogonadism, we know that that can obviously occur in conjunction with opioid use, as can adrenal insufficiency with chronic opioid use. Tolerance, physical dependence, hyperalgesia. We often don't think about the fact that when our patients are on opioids chronically, we may be making their pain worse. And that's what hyperalgesia is. And it's interesting when patients are told that if you really sit down and talk about that risk, it can often lead to them making a different decision. So addiction in vulnerable patients, there's different studies that have looked at the likelihood of developing an opioid use disorder in chronic pain patients, and ranges anywhere from 10 to 40% depending on which study you look at. So clearly, as we talked about, the chief hazard of opioids is respiratory depression. And if we don't recognize that immediately, it can lead to death. And it's really important that not only our patients be educated, but their family members be educated on how to recognize respiratory depression and what to do about it. It's clearly manifested by a decreased hunger for air, a decreased desire or need to breathe. And shallow breathing occurs. The brainstem is less sensitive to carbon dioxide because of opioids. It blocks that feedback loop, and that's what can occur there. So we need to educate family members, talk to them about what to do, encourage them if they have someone in their family, or encourage our pain patients to educate family members on what to do in case of an overdose, and make sure they understand they should be calling 911, but they should also have naloxone available and know how to use it. You know, one of the things that I tell my patients when I'm educating them, and I always tell them it's the most important thing I'm ever going to tell them about their opioid use, and that is that not all overdoses occur because they overtook their medication. Overdoses can occur when people are taking the medication exactly as prescribed. All it has, a liver function issue, a different medication is added. We know that the risk of opioid death is 10 times higher if somebody's on a benzodiazepine, for example. So telling our patients that you might be taking these medications precisely as prescribed, but you can overdose, and you need to realize that. They take it more seriously that way. So respiratory depression is more likely to occur in the elderly. Certainly there are some conditions where it would be contraindicated to use an opioid, someone with severe emphysema, that sort of situation. We need to do everything we can to reduce the risk by making sure that we prescribe the dose that's lowest that we possibly can. We only titrate when it's essential, and make sure that we don't overestimate what we prescribe when we're doing rotation from one opioid to another. We also need to make sure that our patients understand that they should not be crushing their extended release opioids. Sometimes they do that, believe it or not. I mean, we know that some people do that purposefully to get a high or to create an immediate release effect. And clearly, we shouldn't be prescribing opioids to that subgroup. But there are some patients who, in a very innocent way, maybe even an attempt to taper, to take less medication, might cut a long-acting opioid, turning it into a short-acting and do themselves harm. So they need to be educated on the importance of not doing that. Okay. When do we move from an immediate release product to an extended release? If somebody has around-the-clock pain, we want to maintain more stable blood levels, they're not having efficacy, those are the most common reasons. Frankly, we know that opioids aren't that useful for chronic pain anyway. So if you're using short-acting opioids and they're not getting adequate pain relief, the knee-jerk shouldn't be to go to an extended-release opioid. It should be, let's look and see what else we can do to manage your pain. And I think that going to long-acting is a last resort option. Okay. So, considerations when we're changing to extended release. We need to realize that some products, it's contraindicated to start somebody on an extended release opioid. I will tell you, I never start anybody on any extended release opioid, even if it's appropriate per labeling, even if the labeling says even if the labeling does not say that that's a problem. But there are some opioids where it specifically states that you need to be opioid tolerant before you start them on that extended release opioid. So make sure you're aware of the labeling, such as any extended release hydromorphone or fentanyl product all have, you have to be opioid tolerant to be on that. Make sure that you monitor your patients when you start somebody on an opioid. The biggest risk is in the first 24 to 72 hours. Make sure you monitor then. If you rotate somebody to a different opioid, having follow-up pretty soon after the rotation, I think, is a very important thing. One last thought before we leave extended release opioids that I think is just crucial. There was a study published in JAMA back in 2015 that showed that if somebody was started on an extended release opioid as their initial opioid therapy, that their risk of respiratory depression and death was 2 times higher, more than 2 times higher. And that risk kind of went down after about 2 weeks. Now, that study was flawed a little bit because 25% of those patients, the initial opioid that was started was fentanyl. But it's still an issue that we need to really be aware that starting somebody on extended release opioid probably is not a good idea. So what is opioid tolerance? If labeling says you have to be opioid tolerant, how do we define that? And Food and Drug Administration has defined it this way. And these aren't necessarily equianalgesic doses, but this is the definition that is used out there for tolerance. So these different products, 60 milligrams morphine equivalent, or 25 micrograms fentanyl, 30 milligrams oxycodone, 25 milligrams oxymorphone. And I know that this doesn't necessarily compute from an equianalgesic standpoint, but this is what's used, 8 milligrams hydromorphone. So what is opioid rotation? It's changing from an existing opioid regimen to another different opioid regimen. There are various reasons to do it. Probably the most common reason is to take advantage of incomplete cross-tolerance. So just because you're tolerant to one opioid does not necessarily mean that you're also tolerant to another opioid. So if the current opioid isn't working well, one option, rather than escalating the dose, might be to rotate to a different product. So the bottom line, though, with opioid rotation, because of incomplete cross-tolerance, you're going to need to lower the dose. And I have another slide, just a little bit, that talks about that. There are various equianalgesic dosing tables that you can use when you're considering opioid rotations. There's some that are published online. I happen to like the practical pain management one that's online, but there are others. I don't like the practical pain management fentanyl part, but for the most part, I like that one. But there are many different options out there. CMS has one online that you can look at. Just Google that, and that's a pretty good one. Although it's not one that will calculate it for you. You have to look at conversion factors. So this is an example of an equianalgesic table showing that 2 milligrams of oxycodone equals 3 milligrams of morphine if both are given orally. 30 milligrams of morphine equals 20 milligrams oxycodone. 30 milligrams hydrocodone equals 7.5 milligrams hydromorphone. If you look on the far right, those are typical starting doses that are given out there. The doses underneath that are in parentheses, those are for people with hepatic or renal problems or with elderly patients. So again, a little bit of the rationale behind rotation of an opioid and this issue of incomplete cross-tolerance. There are many different mu receptor subtypes, and each opioid binds these different subtypes differently at different levels, and because of that, one opioid may be experienced as more potent in one person who has a certain mu receptor profile versus another patient who has a different mu receptor profile. Similarly, if you have somebody on one opioid that binds certain mu receptors one way and then you rotate to a different one, you may get a different analgesic effect because of different mu receptors. And that's really the rationale behind opioid rotation. The recommendation generally is that you reduce a dose by 25 to 50%. If you're on higher doses, be closer to 50% if you're going to calculate out an equianalgesic dose and rotate to a different product. You may underestimate what they need, but it's better to underestimate than overestimate, and that's why I try to see patients back pretty quickly after a rotation event, and also make sure that I'm accessible to them and to their family members, because you could do somebody harm with this rotation if you overestimate. And it's also really important that with methadone that you're even more cautious. When rotating to methadone, the recommendation is you drop the dose by 75 to 90%. And the reason is methadone, with its very long half-life and a whole bunch of other issues from a metabolism standpoint, is quite dangerous. There was a study published in 2017 that looked at 2014 data, but that data showed that in that year, 2014, 22.9% of all the deaths from prescription opioids were in people that were taking methadone, and only 1% of the prescriptions were methadone prescriptions. So it is disproportionately risky, and rotating to that is something that I would very much avoid. There are some advantages to methadone, but those advantages I don't think justify, and that's my personal opinion, in most situations. And I'm not talking about medication-assisted treatment for opioid use disorder. I'm talking about for pain, where people are out in the community. Okay. So again, I just mentioned this. A couple of other pearls: if somebody is rotating to methadone, no matter what your dose that you're on of the other opioid, it's never recommended to rotate to more than 30 to 40 milligrams of methadone because of its very significant risk. If switching to transdermal products, fentanyl or butrans, there's some very specific product information that you can find in the prescribing information that put out by Food and Drug Administration for these products that will tell you exactly how to do it. It's pretty simple. I mean, this is pretty self-explanatory when you're calculating out. You go to the equianalgesic table, you look at the different conversion factors, and it's very easy to calculate out what the dose of the product to which you're rotating, and then you just drop it by 25 to 50%. And again, closer to 50% if you're dealing with higher doses. Okay. When people have severe, chronic persistent pain and they're on a long-acting opioid, sometimes people choose to give them breakthrough pain medication for breakthrough pain events. If that is a choice that is done, it's really recommended that the breakthrough dose be about 5 to 15% of what the patient is taking with their long-acting medication. All right, so be ready if you're treating patients with opioids. Be ready to refer for opioid use disorder. There's the SAMHSA, the Substance Abuse and Mental Health Services Administration, have a facility locator online that you can go to and find facilities to treat opioid use disorder. Also, for high-risk, complex patients where they're having great difficulty, you may choose to use a pain clinic. So urine drug testing, I like this point that this slide makes, which is urine drug testing is done for the patient, not to the patient. Okay, we're monitoring compliance, but we have to be really careful not to set ourselves up as the police and the patient as a villain. And I will tell you that opioid use disorder, addiction, it's a disease. It has psychological, it has environmental, it has genetic components to it, but it's a disease nonetheless. And we need to make sure that we remember that that's what that is. And when we're finding things that are evidence of that disease, we need to be careful not to be too judgmental. I don't think any of us have to look too far in our lives to see someone or know someone who has this disease of addiction. I'll share with you, it's been, in 2 months, it will be 5 years since my brother died from the disease of addiction. So I'm intimately familiar with that disease and what the impact it can have on families and lives. And I'll tell you, he was a really good guy. He's a really good guy. I still have his last voicemail on my phone that I listen to intermittently to hear his voice because it's important to me. And so we need to be careful when we're doing this. We don't look at this urine drug testing results and say, aha, I gotcha. We need to look at this urine drug testing as what it is. It's evidence of a process, of an issue, and we need to figure out what that process is and what we need to do. It helps us identify misuse. It helps us identify addiction. It's not diagnostic of that. Immunoassays are notoriously inaccurate. There's significant cross-reactivity. GCMS and LCMS is much more accurate. And I just rarely, we don't use any immunoassays in our clinic anymore. Everything is LCMS or GCMS. So how long do these substances stay in the urine? Okay, so it depends on the product. It depends on the metabolism of the patient, the lipid solubility of the product. For most of the drugs that you're testing for, it's like 1 to 3 days. For those that are more lipid soluble, it's longer. So it just depends on the product. This is what the core REMS data shows for these different products. I don't agree with all of it. I mean, they're ranges. If you look at THC, for example, it's interesting because with THC, if somebody has a exposure of just one exposure, they just smoke marijuana once, it's usually about 3 days. If someone smokes marijuana 4 times a week, it's 5 to 7 days. If people smoke marijuana every day, but not multiple times per day, it's 10 to 15 days. If someone smokes marijuana multiple times daily, it can be more than 30 days. That's all, what I just quoted is all from Mayo Clinic data. Okay, so it's very unlikely that someone comes in they were sitting in somebody's car and it was 3 weeks ago, and their urine drug screen is positive for THC, for that to be due to secondhand smoke. Nevertheless, there is a lot of individual variability for a lot of reasons, and so it's hard sometimes to really know what this means. Methadone is usually in there for about a week. This says, 1 to 3 days. I think that's not accurate. Mayo Clinic says it's about a week. Buprenorphine isn't on there. It's about a week. Benzodiazepines, it depends on the benzodiazepine. Triazolam, I think, is probably 2 days. Valium is about 10 days. Most of the others are around 5 days. It just depends on the benzodiazepine that we're dealing with. So when we look at urine, we look at the color, clearly. Within 4 minutes of giving the product, you should take the temperature, or the patient giving the urine, you should check the temperature. It should be over 90 degrees if it's been within 4 minutes. The creatinine level is really important. It varies with hydration. If it's greater than 20, that's normal urine. If it's less than 20 but more than 2, it's probably dilute. If it's less than 2, that's not compatible with human urine. So when we interpret this, we have a positive result or a negative result. So a positive result demonstrates recent use. It does not diagnose addiction. It does not diagnose physical dependence. It does not even diagnose impairment. And it doesn't provide enough information to even determine the dose that they were taking. There are some companies out there that claim sometimes, oh yeah, we can tell you, we can monitor compliance if they're taking the whole amount. There's so many factors that play a role there, that's probably not true. But it does tell us that the patient is taking the drug or not. A negative result doesn't necessarily mean diversion. It could be that the patient is binging and taking most of the prescription the first couple of weeks and then not taking it later, or running out early, taking extra medication or other things. So we need to look at this for what it is, and it helps us in our clinical decision making. When we look at opioids, there are different metabolites. So if somebody uses codeine, it metabolizes primarily to morphine, although there's some hydrocodone. Someone uses heroin, they can practically use it in the parking lot of your clinic. And if they urinate once before they give your urine test, they're not going to probably have heroin there, although they will have 6-monoacetylmorphine, which is the metabolite. But by the next day, that's gone. And after that, what you're really going to see is morphine. So hydrocodone, it metabolizes to the primary metabolite, which is norhydrocodone, and a lot smaller percentage to the active metabolite, hydromorphone. It also has a minor metabolite of dihydrocodeine. Okay, so red flag. You decide not to request routine risk assessment for fear of creating conflict. Mrs. Lane and her family have been your patients for years. She has chronic headache and back pain treatment. When you ask her to take a urine drug screen, she becomes upset and accuses you of not trusting her. You decide against further risk assessments because you are concerned about damaging the relationship. So clearly, we can't do that. We need to have established protocols. The frequency with which we do our monitoring can be according to risk. It doesn't mean that we have to test every time, but we need to have a protocol that we provide, that we apply equally to our patients depending on their risk level. We may urine drug screen someone that's at a high extreme risk more frequently than someone that's at low risk, but we need to be as objective as possible in determining what we are assigning as risk level, and then we need to follow our own protocols. Okay, so reasons for discontinuing. It can be as simple as the pain has resolved, or that the patient just wants to discontinue. I mean, I have patients come to my clinic now and then that say, I feel like this opioid really helps me, but I've been following this opioid epidemic, and I see what's happening, and I want to come off. And I have occasional patients who come in and say, I have a family member who passed away recently. I think I should get off of this drug. So a patient desire, of course, needs to be honored. If their pain level decreases, patients also need to be educated, and not just once, but frequently, about risks. And sometimes they make that choice to come off, and then we need to give them the helps and be available. There was a study by a physician with the last name of Franks, I think it was in 2016, that showed that having a provider that's accessible and available and supportive is one of the best things you can do in tapering. If patients feel like they're going to be alone, if they feel like you're not there to support them, then tapering is going to be much less likely. Clearly, there are some situations where tapering is going to happen. And we need, somebody that is having aberrant behaviors that are significant, or they're using illicit drugs, or they're selling their prescriptions, or they're diverting, those kinds of things. There are lots of different reasons to consider tapering. Sometimes it's working for their pain, no aberrant behavior has occurred, but they've developed new medical conditions that make the risk greater, and tapering needs to be considered because of their recently diagnosed emphysema or whatever. Okay. When we taper, we should not, when we discontinue, typically you do not discontinue abruptly. You want to minimize the likelihood of withdrawal by tapering gradually. Unfortunately, there's no real good guidelines out there in the literature about how to do it. There's a lot written about how to do it, but not very much that's evidence-based. So it's an individual thing. You can maybe go as slow as 10% per week or as rapid as 25 to 50%. CDC in 2016 talked about when people are on really high doses, you may need to go really slow and, in fact, sometimes pause the taper for a time and then go back to it. Giving counseling and some relaxation strategies and other things might be helpful in that process. So some general pearls for practice. We need to make sure that we're giving informed consent to our patients, talking about risks and side effects. Give a medication management agreement to our patients. Make sure that they have the facts about the opioid situation. And that we not just educate the patient, but their family members so that they know, and they know what to do in case things happen. If we are out of our depth, we need to be willing to refer. We need to anticipate opioid-induced respiratory depression. Somebody that has sleep apnea, for example, they're at much higher risk. They need to be treating that. I've had patients where I've said, look, I'm not even going to prescribe this unless you have this sleep study. We need to get this sleep study because look at all your risk factors. So we need to make sure that we're going through those risks, and particularly follow closely if you adjust the dose. Those are very vulnerable times. And if you are going to work on discontinuing, do it slowly, typically. The patient should be part of that process, though. Sometimes patients want to be a little faster. And absolutely, this should be a shared decision-making approach as we work on tapering. So Donald has been prescribed oxycodone for 6 months to treat back pain. His urine drug screen at 6 months came back negative in all areas. He tells you that he's taking his medications. So he's got a negative drug screen, but he denies not taking. So the first thing is you don't automatically assume that he's diverting. You don't automatically assume that he's binging. What if it's an immunoassay? Immunoassays, for example, are very poor, at least most of them, at looking for oxycodone. So it could be that it was an immunoassay that was done, not liquid chromatography. So we want to make sure that we contact the lab, we make sure that our information is accurate, okay? And then sometimes we choose to repeat the lab test, but also, we need to make sure that we talk about this with the patient. I typically will sit down with them, and even if I'm thinking, I think this is a false positive, I think this was an immunoassay that came from another clinic, this is the first time this is an immunoassay, I still say, this was positive, can you tell me what happened? Or this was negative, have you not been taking it? Give them a chance to tell you what happened. It's amazing how often that they will come clean on those things. Okay, Tom has back pain. He is managed by taking oxycodone, an extended release, 40 milligram twice daily. But he wants to decrease his dose when he can. Thus, he requests only 20 milligram pills. He often brings in unused meds to show how he's trying to reduce his dose. He resists any changes. So that's not really a good thing. You know, though we use a shared decision-making approach, and the patient should be absolutely engaged in the decision of how we're going to taper, we should establish direction together and then follow it. And a patient taking first off, it's not recommended at any time that long-acting extended-release opioids be given on an as-needed basis. And to have somebody do that in this way, plus this is a setup for diversion, right? Because I've got multiple 20-milligram pills. So there's a whole bunch of red flags here. So if he wants to taper, we should decide how we're going to do that, establish together, he and you, need to establish together what the plan is and then follow through with the plan, but not give him this whole bunch of pills and you just go ahead and taper them as you would like. All right, thanks.
All right, on to special populations. This will be about the elderly, the young, and the pregnant. The good, the bad, and the ugly. I won't say which one's which. Older adults. This is all common sense stuff, but we have to give it to you. This is part of the REMS program, so I know you know these things, but we'll review them. Obviously, in older adults, we are concerned about respiratory depression, so we're going to want to lower the dose of opioids. We're concerned about age-related changes, such as in distribution, metabolism, excretion, and absorption. So our motto is to start low and go slow for all patients. For older patients, we want to start lower and go slower. Remember, there's polypharmacy going on. They're at increased risk for falls, cognitive changes, psychosocial status issues. So reduce your dosing to about 1/3 to 1/2 that you would normally give a regular adult. And then another risk with the elderly is the caregivers. It's amazing how many grandchildren become more interested in grandma and grandpa when they find out Percocet is in the cabinet. So keep that in the back of your mind as you start to see more attentive grandchildren or family members around your elderly patient that has access to opioids. Also, they're more susceptible to constipation, and you need to treat that aggressively. Women of childbearing potential. 40% of all women of childbearing potential are prescribed opioids. There's really no adequate information or studies on opioids and pain during pregnancy. A lot of women do not know they're pregnant in the first few weeks, so when you have a woman that's in the childbearing ages, just consider that before prescribing opioids. When they're pregnant, again, because of the potential risks, we want to try to encourage them not to use opioid medications for their pain. That's easier said than done, and I realize that. If they're on chronic opioid therapy, we need to really educate them about their risks, try to minimize the dosing, maybe consider referring them to a high-risk OBGYN. I have one problem with this bottom statement. It says, if using opioids daily, consider methadone or buprenorphine. This is a core slide. I do OB anesthesia, and I have seen patients on buprenorphine post-operatively, and they are very difficult to manage. So if they're getting buprenorphine for an addiction problem or methadone for an addiction problem, I would agree with this. Otherwise, buprenorphine is somewhat difficult to manage in a post-operative setting. So I would consider that twice, depending on what medications they're on. Methadone, if you're not a regular prescriber of methadone and you don't understand methadone, I do not think this is the time for you to learn how to start methadone. It's on your pregnant patient because this slide said we recommend methadone. Methadone is very tricky. It's got biphasic metabolism. The respiratory depression lasts longer than the analgesic effect. So unless the patient's already on methadone for drug addiction, I'm not sure if I completely agree with this slide. But I have to present it to you because it's a core course. Children and adolescents. Again, Children are very susceptible at a young age. We want to avoid opioids, but of course there's going to be a need for opioids in some children. It's recommended that we use immediate release opioids that, and brief therapy. If it's those special circumstances where there's cancer involved, where they're a hospice patient, or they've got a chronic disease that requires chronic opioids, then you may want to consider a pediatric palliative care or a pediatric pain specialist. There's no good established studies for long-acting opioids in children except for transdermal fentanyl. It has been approved for ages 2 and older. This is the red flag. This is basically diversion from a grandma to a grandchild. That's what we're looking for. We're looking for those signs of diversion in our office. I'm not going to give you this one. I'm going to give you a personal story that happened to me about 20 years ago. I had about an 85-year-old woman that had a non-union fracture of her femur. She was not a surgical candidate. She was on fentanyl patch, and I don't remember the dose. I think it was 100 micrograms, but I don't remember. And she also had breakthrough medication, Percocet. This was 20 years ago. This is when we did higher dose opioids and breakthrough pain medications. She was doing stable on that medication for a long time, and then one day she shows up with her new caregiver. Her new caregiver was the Relief Society president. Very nice woman. She was very, she took this elderly lady shopping. She helped her every day at home, and she changed her patches for her, and she helped her with her medications. The woman said the medication was no longer working and she needed an increased dose. You know where this is going. The older woman also said, these patches don't stick anymore. They're making them cheaper. They don't stick anymore. And my pills are running out. I need more pills. So I asked the Relief Society president to leave the room, and I had to do an exam on the patient. And when the Relief Society president left the room, I said, when did the patches stop sticking? About 3 months ago. When did your new caregiver show up? About 3 months ago. And she's so good to me, she puts the patches on for me. I said, when did your pills start running short? About 3 months ago. And I asked the elderly lady, I said, is there any chance you think that this new caregiver is using your medications? She goes, I thought that, but I didn't want to accuse her of that, because she's been so helpful around the house. So I asked the young woman to into an exam room with a witness, and I said, and I proposed that she might be doing this, and she said, yes, I am. Please don't tell my husband. This will be the second time I've been caught being an addict. We informed the authorities, and she doesn't like me very much. There's a much better end to that story, I'll tell you after the discussion. You need to know your federal and state laws. And those are hard to keep up with, especially in today's opioid crisis where new laws are being pushed out. We are going to give you the review. If you understand the Utah legislation, you will be meeting the federal legislation laws, because Utah is following them very closely and keeping us up to date on all federal laws as well as the Utah legislation. So we're going to basically emphasize Utah legislation today. First of all, the reason why you're here right now is you are now required to do 3.5 hours of opioid education and then an additional half hour when you reapply for your license. So a total of 4 hours. This is required for all physicians, physician assistants, and nurse practitioners if they're prescribing Schedule 2 through 5 medications. So that's why you're here. It's House Bill 175. It makes it Utah law, and it didn't matter if they made it law or not. DOPL says you have to do it. The one thing they're emphasizing is that you review the prescription drug monitoring programs. This is the DOPL report. This is when you look up and you see how many doctors are prescribing opioids, are there benzodiazepines, what drugs is this patient getting from other people. It's a great report. Every state is different. Every state manages this differently. Some states don't even have one. Utah has a great one. In Utah, and if you're not registered for the PDMP, write down this website right now. If there's anything you do today, you got to get registered. It is now a law that before you prescribe opioids, for the first time, you have to look up this report. Now, you can have a designee in your office do this for you. The designee has to have a background check through Doppel. The easiest way to do that is if your designee has a license through Doppel, it's a much easier process. So like a nurse in your office. The designee can look up your reports for you, so you don't have to take the time to do it. The one thing they can't do is they can't log into your patient under your name and then look at somebody else's patient under your name. They have to actually log in and log out for each provider. Also, if the designee leaves your practice, you need to call Doppel and immediately take them off that the ability to look at your patient's Doppel report. I call it a Doppel report. It's the PDMP. Here in Utah, they watch Schedule 2 through 5. Both the dispensers and the prescribers have to register. The dispensers have to give information within 24 hours. We're one of those lucky states that we do communicate across state lines, so we get information from nearby states. This is actually a great tool. This is like looking at a lab report or an x-ray report. If you haven't done it, it's amazing how many times you've been fooled by somebody, and then you look at this report, and you find something that's just, they're in there and they've convinced you they need 30 Percocet, and it sounded real, and then you look at the report, and they just got 30 Percocet 2 days ago from the guy down the hallway. It's also, some people don't know what a benzodiazepine is. They don't know that sleeping aid that they've been giving is a benzodiazepine. So it really is a great report to review before you give out a prescription. This is what it looks like. The great thing about the Utah DPM is it has these metrics. The 4 metrics, they follow the CDC guidelines, which is not perfect, but it's something. And they will label your patients at high risk, medium risk, or low risk. And if they're a high risk patient, this will be red, be flagged in red. If they're medium risk, it'll be flagged in yellow, and if they're low risk, it'll be flagged in green. Daily morphine milliequivalents, if they're less than 50 morphine milliequivalents a day, they'll be considered a mild risk. If they are 50 to 90 morphine milliequivalents a day, they'll be considered a moderate risk, and if they're greater than 90 milliequivalents a day, they'll be considered a high-risk patient. Number of prescribers and number of pharmacies. If they have 5 or more pharmacies or prescribers, they're considered high risk. If they have 3 to 4 prescribers or pharmacies, they are considered medium risk. If they have 2 or less prescribers or pharmacies, they are considered low risk. If there's any benzodiazepines and opioids combined, they're considered high risk. So it's actually, we got a great report here in Utah. Again, House Bill 127, the first time you prescribe a controlled substance, you have to look at this report. Let's talk about marijuana. Utah has gone green. I don't know how they picked that color, but green is the color of the states that allow medicinal marijuana. And then orange is the where you can use CBD, but not high concentrations of THC. And then the white states don't allow it at all. Utah now, as you know, allows medical cannabis, medicinal cannabis. This is still breaks the laws for the federal government. It is still a DEA Schedule I considered high risk for abuse. Obviously, they're looking the other way. Multiple states have this medicinal use of cannabis. There is evidence that cannabis is beneficial in pain patients. The evidence is not great. There's contradictory evidence. It's a lot more research that needs to be done, but there is a useful tool for cannabis. We're still very concerned about the high risk of abuse, especially if it gets into the hands of children. We'll talk about that more in a second. I am not an expert on medical cannabis. I just read a few of these websites before I got up here tonight. These are the sorts of websites that I went to. The best one I saw was Utah Medical Association. They almost immediately had a medical cannabis outline for physicians to figure out what you should do about writing a letter of recommendation, what your options were, what your concerns were. It was very well written, and it came out almost the day after legislation was effective. Intermountain Healthcare came out with another form that was great. It's called Cannabis 101. If you're an Intermountain provider, you can go to the educational area and read Cannabis 101, or you can take the time to write down this huge link. And then, of course, there's government sites. Probably the best one is healthutah.gov for medical cannabis. Keeps us up to date on a daily basis because there's constantly changes going on in this legislation. Again, I am not an expert on medical cannabis. As a matter of fact, the expertise I get, I call some of my old college roommates that did some special research in college. That's where I get most of my information from. But there are different types of cannabis. There's different variants of how much THC versus CBD. It's the CBD component that has the most effectiveness for chronic pain, so higher concentration of CBD is going to be better. And I think we're going to get more education coming up here in 2020, where we're going to be required to have 4 hours of education if you're going to be a letter writer. So who can write letters? Anybody that can prescribe Schedule II medications can write a letter of recommendation. So MDs, DOs, PAs, and nurse practitioners. This is not a prescription. You do not want to call it a prescription because it's, again, not, the DEA is a federal government, and it is a recommendation. To write the letter of recommendation, you must have a relationship with this patient. You have to have a real doctor-patient relationship or provider-patient relationship. Eye-to-eye contact. The patient has to have one of the qualifying conditions, which I'll go over. You must believe that this will benefit the patient. You must discuss the risks and the benefits with the patient and document that well. You must consider drug interactions. You're supposed to use the medicinal dosage forms approved by Utah law. I haven't actually not seen them. I have not written letters yet. I'm actually waiting until they have the qualified medical provider education before I start writing letters. The qualified medical provider is what happens in 2020 to write a letter after 2020, and I believe it's going to be in March, but they don't know exactly when. If you want to continue to write letters of recommendation, you have to take a 4-hour course, so another one of these courses. That's good, right? Somebody laugh. So if you're going to write letters of recommendation, you currently can write one for 175 patients. Unless you're a specialist in one of the areas where the qualifying diagnoses are, such as an anesthesiologist, I'm assuming they're talking pain physicians, gastroenterology, neurology, oncology, pain physician, hospice and palliative care, physiatry, rheumatology, and psychiatry. Then you can write 300 letters. DOPL can approve you to write more letters, but you have to qualify and contact DOPL for that approval. Qualifying illnesses: HIV, AIDS, Alzheimer's, ALS, cancer, cachexia, a condition of physical wasting and malnutrition associated with chronic disease, severe nausea not responsive to traditional medicines, Crohn's disease, ulcerative colitis, epilepsies of certain types, MS, debilitating muscle spasms, post-traumatic stress disorder, autism, terminal illnesses with 6 months to live, hospice care, and then the unique one, something that affects less than 200,000 people in the U.S., a rare condition that they didn't think about. When they looked at all the medicinal cannabis states and what the #1 prescription was for, in all the states that have medical cannabis, it's for chronic pain and debilitating pain. The types of cannabis that you can prescribe, or not prescribe, you can write letter recommendations for. It's going to be tablets, capsules, concentrated oils, liquid suspensions, topical preparations, transdermal preparations, sublingual preparations, gelatinous cubes, which will come out in 2020, unprocessed cannabis flower in a blister pack that has restrictions that apply, waxes or resins if 2 or more of the above did not work. So you can vape medical cannabis, but you cannot smoke marijuana or cannabis. It cannot come in the form of candies, cookies, or brownies. For obvious reasons, we're trying to keep it out of the hands of the kids. Utah has no legal license channels at this time. We're expected to get those in 2020. So for your patients to get their medical cannabis, They have to cross state lines with their letter of recommendation, get the appropriate amount of cannabis, not to exceed the appropriate amount, and then it's against the law to cross state lines with medical cannabis, but I'm assuming if they have a letter of recommendation and the appropriate amount of medical cannabis, police officers will look the other direction. There are drug interactions. The best talk I've ever seen I've been to several talks on medical cannabis at the Academy of Pain Medicine. I went to one in Canada. The best talk I've ever seen is actually through Intermountain Healthcare, through Sarah Yost and Bradley Winters. If you get an option to see this, it is the one that gives the most information about medical interactions, the most about the real medicinal use of cannabis. The biggest problems is dosings and how to do it. If you do get an option to see these two talk, it's a great, it's about an hour lecture in and of itself, and it's a great medical cannabis talk. So the drugs that they were most concerned about were warfarin, alcohol, theophylline, and clobazepam. Considerations if you're going to write a letter. Use available scientific evidence to advise your patients. Inform about potential effects, adverse effects. It says coughing here. I'm assuming that's associated with the states that allow smoking of marijuana. I suspect vaping may cause coughing as well. Screen for potential misuse, abuse, and diversion. Set up a PPA, agreements with your patients. Encourage patients to keep notes and discuss them. Document everything. Regular reevaluations. Consider periodic drug testing. Discontinue if it's not helpful. Edibles are the fastest growing delivery system. There is no well-controlled studies on the combination of medical cannabis and opioids. So you may choose not to mix the two. You need to walk carefully if you are going to mix opioids and medical cannabis, because there's no studies that completely understand how the two are going to interact in the long run. Let's go back to opioids. House Bill 50. This it was written in 2017, but really came effective in 2018. Some of you probably noticed it. You got denials when you gave too many pills. You have to give a 7-day or less quantity for your acute pain patients. Some surgeries, you can give more than 7 days, but you have to document that. Obviously, chronic pain and chronic conditions, you can give more than 7 days, but you can no longer give more than a 7-day. It's actually, they're considering recommending 3 days, because most patients only take their pills for a short period of time. They don't need the full 7 days. Consider that with your diagnosis and your patients if they need less than 7 days. Once again, you have to check the PDMP prior to writing it for the first time. House Bill 146, partial filling. So you think your patient's going to need 10 pills, but they might need 20 and you don't want to get a phone call. You give them a prescription for 20 pills, but they only get 10, and they can go back and get the other 10 later if they need them. This is now allowed in Utah, so you can do a partial fill. House Bill 286, Essential Treatment and Interventions Act. This is when a family member is concerned about one of their other family members and they think there's a drug issue, they can get the court-ordered intervention on a family member. House Bill 90, this is an insurance opioid regulation. This means the insurance companies can watch over us and watch our prescribing habits. This got a lot of people, a lot of pain doctors, very nervous because they thought the insurance companies would abuse this and use this as a way of decreasing the cost of some of these patients. The insurance companies can already do that. This was just legislation saying, hey guys, keep an eye on some of these doctors and call them on it. If they're combining benzodiazepines and opioids, ask them why. Have them at least document why they're doing it. If they're a high prescriber, maybe they got a unique population, but ask them why and get verification of why the patient needs this. A lot of insurance companies are doing that. I'm currently on part of the panel at Select Health where we review some of the high prescribing physicians, and then we go in and we ask them, why is your patient population different than the other people that practice in your discipline? They're also encouraging medical assisted treatment programs and, of course, the use of non-narcotic treatment alternatives. House Bill 191, Controlled Substance Abuse Amendments. Gaylinn talked about informed consent. Well, now when you prescribe an opioid, you're supposed to do it informed consent, but now you better document what you told the patient, because it's now a law that you have to tell the patient about the risk of addiction and overdose, the alternatives that they have, why they're getting the prescription, the dangers of mixing opioids with alcohols, benzodiazepines, and CNS depressants, and the risk of any other drugs prescribed along with the opioid. This is something that you cannot have a delegate do. You have to do this yourself. So if you're prescribing an opioid, you have to have that discussion with your patient. This cannot be your MA or your nurse doing this discussion for you. House Bill 186, opioid prescription amendments. This allows DOPL to oversee you. So your insurance companies are going to be watching you, and so is DOPL. And if you appear to be out of the norm for your discipline, they may contact you and ask you why. It may be that you have a unique patient population. There may be a very good reason why you have it, but they may reach out to you and say, what's going on here? And they can consult with you. They can also, if you have a death and it undergoes, the medical examiner relates this to an opioid death or a prescription overdose, they can review that as well and then discuss it with you. You do not have to discuss with them the case. You can decline to discuss with them. It will not be held against you. I would advise you sit down and talk to them, but that's something that you can consider if you do. You can decline the option to talk to them. You are supposed to know the Utah clinical guidelines for prescribing opioids. This is the website for that. This is about 90 pages. It's really fun reading. I have read it a couple of times. The best part about this is it's got 2 summary pages that are very good summaries. I used to put them over on the table, and no one ever took them, so I decided not to kill a tree this year. If you want the summary pages, it's a great summary of this course. It's a great summary page to give to some of your people that you work in your office that want the quick abbreviation of this course. I will not regurgitate the acute pain or the chronic pain summary to you now for the sake of time. We are trying to promote naloxone. This is something that we consider good. We want as many people to have naloxone in their pockets or at their homes as possible. You can give it to a third-party member. Patients don't even need a prescription to get naloxone. They can ask for it at the pharmacy without a prescription. There can be a standing order for it. It's very liberal. We want that out there. We want you to encourage you to think about using naloxone on your patients that you're concerned about. I believe we will talk about naloxone, or we already have. I'm not sure which order, but naloxone, you should consider it if the patient's on chronic opioids, long-acting opioids, if they have risk factors that increase the risk of respiratory depression or respiratory compromise, such as respiratory disease, sleep apnea, obesity, and then, or for any patient you're prescribing an opioid. You should discuss an overdose plan with your patient. Remember that the patient's not going to be self-administering naloxone, so it needs to be discussed with family members or friends that are going to be with the patient. The naloxone needs to be available, so it should not be locked up with the opioid in the opioid cabinet. It should be out and accessible. When they do administer naloxone, they need to call 911 because the duration of naloxone is going to be shorter than the opioid half-life, so 911 has to be called after naloxone is given. It comes available in injectables and nasal sprays. The CDC recommendations. Now, we've already gone over these once, so I'm not going to regurgitate them again, except for I am going to say the CDC just put out a letter stating that these are not written in stone. There's reasons why they came up with the 50 and 90 morphine meal equivalents, as we learned from Robin, because of the increased risk associated at these levels. The American Academy of Pain Medicine is having issues because a lot of insurance companies and a lot of legislation and a lot of things is using these numbers as law. So the CDC just, I think, last week came out with this is not written in stone, this is a guideline, and there's going to be cases where you're going to exceed 90 morphine meal equivalents. And again, Gaylinn already went over these, so I won't repeat it. Our next speaker is Gary MacDonald. Gary is a rock star. Gary's a family practitioner that was asked to take on a significant problem at a certain pain facility that lost their pain physician. These patients were some of the most difficult patients, very high dose medication management, multiple opioids with benzodiazepines, everything that you're worried about, including intrathecal pumps. He went in and he basically gave himself a self-fellowship in pain medicine. He's probably one of the best pain medicine doctors in Utah now. He is going to go on to get a pain fellowship and continue in pain medicine, and he is a wealth of knowledge. Gary?
Well, it's almost over. You have me for cleanup. So I'll be talking about counseling and some medication interaction issues. So this is a patient counseling document that CORE says that all patients should have with them, covering do's and don'ts, things that they should keep in mind. We'll cover a lot of the stuff that's in here. I will admit that I ask patients to keep a listing of their medications with them, but they don't exactly carry this. As far as counseling patients, it's important that they understand the difference between immediate reacting and long acting, as Robin talked about. You know, a few rules that we kind of set, you know, for people to keep in mind. Take opioids as prescribed. Don't try to deviate from the prescription. And don't take any other medications that aren't prescribed, or illegal drugs or alcohol. And so that pretty much handles all of this, as well as educating on what they should do if they miss a dose, when it's too early to take the next dose, how long do they have after they miss a dose to take the next dose, or when can they take the next dose early if needed, based on their situation. And then they should notify you if their pain's not adequately controlled, or if they're having side effects. That doesn't always mean that you're going to be able to take care of it right over the phone, but at least you can give some guidance. Surely sometimes some things like itching from medication can be handled over the phone, but sometimes things that seem innocuous, like nausea, could be a much deeper problem and not have anything to do with their opioids whatsoever. And of course, CORE recommends that you inform patients that they read the medication guide that everybody throws away or shreds every time they get a prescription. It's important for them, especially for patients, to tell you all the medications they're taking, but also all the over-the-counter medications, because especially medications like diphenhydramine or other over-the-counter allergy medicines really can interact with these medications, especially when they're on muscle relaxers and TCAs. It's important to warn them that they shouldn't abruptly discontinue the medications. Now, if we're talking about a short-acting medicine that is prescribed as needed, certainly if they want to decrease the amount that they're taking that's okay. But from long-acting, they should not be decreasing that dose unilaterally. A lot of times what we'll find is that they do decrease that dose, and then if they're on an immediate reacting medicine, they end up increasing that to take its place, and that goes down a slippery slope. I also counsel patients not to, when they're taking the medicine, just to be careful about driving, operating heavy machinery, flying airplanes, tossing around small children or animals, anything that they could possibly do that could, when taking the medicines, that could impair that ability. And of course, not to sell or share the medicines. People often think that sharing it or giving it to another person that may need it is kind of innocuous, but it really isn't. It is against the law just as much as selling the medication is. And we already talked about different side effects: respiratory depression, bowel obstruction, allergic reactions. Locking the medicines in the container, that's where, and your ultimate goal should be to have patients lock their medications away. Certainly some circumstances can change where they keep them in 7-day pill boxes if they have a high medication pill burden, but certainly as many as possible should be kept locked away. Some patients I have will even have them in a 2-lock system where one spouse will have the combination for the safe and the other spouse has the keys to it, just to keep everybody honest. And patients should know that we're going to periodically reassess for whether the medication's working, side effect profile, do they continue to need the dose that they're on? And certainly if their medication isn't working, to reassess it. If their medical condition changes, reassess it. This comes down to a lot of times we'll tell patients, we're prescribing these because the benefits outweigh the risks. If at any time that the risks outweigh the benefits, we may need to decrease or discontinue this medicine. And certainly they should be kept away from prying eyes, children, and family members, transients, and other people that are deemed to be risky, and also kept safe from theft. Nope. There we go. We ask patients not to crush, chew, alter, snort, inject, directly insert the medications unless otherwise noted or instructed to do so. Certainly altering the form of the medicine can affect how the patient will react to it and the metabolization of it. This can also lead to rapid increase in the medication in their system. Sometimes on capsule forms, they can open a capsule up and sprinkle them onto food, but they should really talk to the prescriber or their pharmacist first before they alter the medicine. Ultimately, if the capsule's not scored, it probably shouldn't be cut. Long-acting medicine shouldn't be altered in any way. Certainly, alcohol shouldn't be used, and I will tell all of my patients, if you're taking an extended release or long-acting opioid, you cannot drink alcohol. Alcohol will act as a solvent. It will break the drug down faster, and it will lead to a dose dumping phenomenon where they will get more of the dose than is intended. And certainly other sedatives, depressants, anxiolytics, and illegal drugs can interact with the medicine and potentiate the adverse effects of it. To summarize this slide, if they look like they're dead, or they look like they're going to die, or sound like they're going to die, you should probably administer naloxone and call 911. Robin talked about abuse deterrent formulations. I won't go too much into this. I will tell you, talking with various people from the pharmaceutical industry, this really was intended for a downstream user and to decrease the street value of the medication. But certainly I hope it's over time, as patents start to expire, it becomes more readily available. Insurance companies aren't reimbursing it that well and paying for a lot of these. Patients who are parents should talk with their children about the medication, risks, side effect profiles, and be educated early, much like they are for alcohol and some illegal drugs. It's not surprising that 45% of patients have taken pain medicine without a prescription. It's not surprising that 14% of parents have given children pain medicine without a prescription. Once again, we're talking about things that we view as innocuous, but can certainly lead down the slippery slope. Teens don't normally report that they talk to their parents about prescription drugs. And from a social context, evidence suggests that pre-college parental conversation will help this risk. It's happened in this state with alcohol and drugs, but unfortunately not so much so with prescription drugs and opioids. I don't think this slide is that surprising. Beer's obviously the top of the list, alcoholic beverages, as is marijuana. This is a little older. I'm hoping that prescription drugs has gone higher than the education regarding cocaine and crack. I don't even know if crack is still out there. So we should remember, monitor, secure, and dispose. That's how we're going to try to break it down. So patients should know how many pills they're getting. They should know how often they're supposed to take it. And they should keep track of their dosage. And know when they're going to run out of their medicine, so they don't call the office after they're already out. That leads down a problem as well, is that when they run out of their medication and they haven't come to see you to get a new prescription, that their pain's going to be increased because they're out of medication. It can cause them to take other things. It can cause them to immediately get the medicine and take more of it. And then they should also be educated that after a few days, if they ran out of medicine, that they're going to lose some of their tolerance to that medicine. And so taking the dose as they normally would can lead to some bad problems. Make sure everyone in the household that needs to know about the medication knows. So I had a little disagreement with that. Not everybody needs to know. Transients don't need to know. I've had patients who have had transients living with them who have had their medication stolen. Medication should be secured. We talked about the lockbox, and it's kept in a safe place away from prying eyes. And next one is especially difficult. It's how do you encourage patients that have children to tell other parents who also have children about this. More of it should be in a social context as far as a nudge, talking about maybe a story they've heard about an overdose, and maybe that parents should get together and start educating their children about this. And discard unexpired, unused medications. You don't want a pharmacy in your cabinet. And consult the product insert for the best method of disposal. So, the new Disposal Act, which isn't really that new, it's approaching 5 years old in September, expanded the way that we can dispose of medications. So typically we think of law enforcement, pharmacies, hospitals as a way of disposing, but expanded those to include manufacturer takebacks, distributors being able to take the medicine back, or a reverse distributor, which takes from end user back to the manufacturer. But commonly, the most common ones are going to be Sheriff's Department, police station, and pharmacies and hospitals. If you go and you do an internet search for, go onto the DEA website, DEA drug take back, there'll be a link there where you can put in a zip code and find a location near you. And I don't care whether you put Evanston, Wyoming, Green River, Wyoming, Moab, Roosevelt, you're going to find a place within 20 miles where you can dispose of these medications. And there's also another thing, Dispose RX, that people can get. And also you can, some pharmacies, you can get a disposable container that you can put the medicine in, which dissolves it. And so, and what dissolves is probably similar to that blue liquid that's in there. If you go onto Amazon or do a Google search and type in blue liquid RX disposal, medication disposal, you can buy a jug of this stuff that you can then pour into unused medications, dissolve it, and then discard it in the trash. And that's typically, other than take-back events or taking it to a pharmacy or doing what she said, what Gaylinn said is this is another method to put it in the trash. But it should not be put in the trash in its whole unused form typically. Transdermal patches. So the FDA, DEA, and most societies will say after the patch is used, fold it in half, flush it down the toilet. Canada has actually gotten away from that. They're advising people to take it back to pharmacies or hospitals because of their wastewater system. Times when you may not want to do that may be if you have a septic system with a well water, or you have a wastewater propeller pump. As these do not dissolve, they will clog it up, much like wet wipes do, or sanitary wipes can. The exception is Butrans comes with a patch disposal unit that can be discarded in the trash. But also keep in mind when you're talking about a fentanyl patch, a 50 microgram per hour patch has approximately, give or take, 8,400 micrograms in a patch. And after 3 days, approximately 50% of that patch is left. A patch every 3 days over a year, that's over 530,000 micrograms of fentanyl that can go in the water supply. And if you have a well and you have a septic mound, that could be going right into your water supply. They say it doesn't make a difference though, and it's negligible. So use medication management agreements, also known as PPAs, counseling documents to educate patients and caregivers, emphasize safe storage, consider prescribing naloxone. In our practice, every patient that's on chronic opioid therapy receives a prescription for naloxone, either nasal spray or an injectable. If not for them, certainly they need to tell the other people in their household where it is and how to use it. But if not for them, hopefully for someone else, because they're going to know somebody, either a family member or a friend, who's also on chronic opioid therapy. So, red flag. Your patient's daughter stole her father's medicine from his bedside drawer, took it to a fishbowl party or Skittles party, whatever they want to call it. Her best friend consumed a mixture of opioids and alcohol and died. So how could this have been prevented? Education, counseling, safe drug storage. Obviously, it shouldn't have been kept in a nightstand, especially if there was question about the daughter and there was no education provided. Certainly, if the daughter would have known maybe the side effects, the risk of death, and the legal implications are pretty bad. So not only will the child possibly held criminally liable, the parents can be held civilly liable, and I don't know of any court cases yet, but if the education to the patient isn't documented or scanned in their chart, there could be some civil liability down the line for us. Drug class considerations. Know the drug interactions, pharmacodynamics, pharmacokinetics. I think we've beaten a depressant effect and respiratory depression to death. Certainly, the effect can be potentiated by MAOI inhibitors, and with certain opioids such as Nucynta or tapentadol or tramadol, serotonin syndrome with MAOIs. Certainly, everybody who's on methadone or buprenorphine should have an EKG on file to note whether they have a QTC prolongation or not. And if you're starting a patient on these medicines, get one beforehand so you don't find out about it after the fact. We talked about alcohol, dose dumping. Opioids can also increase the release of antidiuretic hormone, which can affect some of your patients on diuretics. If they're starting on opioids, it can reduce the efficacy. And certainly patients who are on chronic opioids and either have a new medicine added or have a medicine that's discontinued or a dosage increase, we need to be mindful of whether it induces or inhibits CYP enzymes. So do not cut, chew, or swallow. Basically, don't alter medicines unless it's approved by the pharmacist or the prescriber. Keep in mind that exertion, when someone's wearing a transmucosal patch, anything that increases sweat production or body heat can lead to increased amounts of medication coming out and absorption. I read a case about, and I don't know if all the truth to this, but a lady had a fentanyl patch on. She went into a tanning bed because of the increased heat and the radiation caused increased medicine to be released and absorbed. She then ended up passing out, waking up 3 hours later with third-degree burns because she fell asleep in the tanning booth or was put into an opioid-induced sleep. It seems like an extreme example. Again, I don't know if that's the whole truth to that, but something to keep in mind. Patients should rotate the location of these patches because of local site reactions. So that's something that you want to encourage and let people know to do. They will develop a preference to a site or a certain body area, and they should prep the skin by clipping it and not shaving it, because shaving it will create microabrasions that will cause increased medicine to be absorbed. And keep in mind that everyone with a fever may not just have an infectious cause to it. It could be opioid-induced, but first I'd probably try to rule out some infectious causes before I'd attribute it to a fever in someone who is feeling okay otherwise and doesn't have sedation effects. And then also with MRIs, probably should take the patch off beforehand. Just because you can't see metal doesn't mean there's not pieces of metal within that transmucosal or transdermal patch. And buccal patches shouldn't be altered in any form or taken if they appear to be damaged. So we've already talked about respiratory depression, hypotension, sedation, coma. It's worsened when people are on taking other medicines in combination with opioids. Certainly the mixture of opioids and partial agonists or mixed agonists, things like buprenorphine or butorphanol, those most commonly used ones, should be discouraged only in some extreme cases. Keep in mind, opioids will also enhance the neuromuscular blocking action of skeletal muscle relaxers. Sometimes we use this synergistic effect to our advantage, but just keep in mind that if you have a patient that's already on a muscle relaxer and you add opioids on top of it, it could increase the effects of it. And something we don't always think about, that opioids do have some anticholinergic action to them. And when you start looking at patients' chart and you start thinking about all the medicines that are in there that have some kind of anticholinergic effect, so they're on opioids, they're on a muscle relaxer, they're on a tricyclic antidepressant such as amitriptyline for neuropathic pain, and oh, by the way, they're for Unisom they take at night for sleep, you're setting up a disastrous situation, especially from a fall risk, urinary retention, ileus, constipation. Product inserts, they should be read. They should be. Not everybody does it. They should know that the extended release medicines are only for opioid tolerant patients, as Robin talked about in great detail. Some general contraindications to opioids would certainly be significant ongoing respiratory depression, untreated asthma, COPD, especially when they have low oxygen levels and they have no oxygen. Suspected or paralytic ileus, obviously, hypersensitivity, obviously, if they have an anaphylactic reaction to opioids, among others. So, what should you know about the products you prescribe? Really everything. We're pretty much all familiar with what the substance is, what the formulation is, what the strength is, what the dosing interval is. But some real things, big things are, where we get in trouble a lot of times, is the relative potency to morphine and drug interactions, because we lose sight of the other medicines that they're on that aren't currently causing a problem. We add one on, suspecting that that won't cause a problem either, and it does. So summary, to assess them, to initiate modified therapy when the risks outweigh the benefits, only prescribe when the benefits outweigh the risk. Consistently monitor, whether that's through your own interview with the patient or through urine drug screens, PDMP, state databases, counsel them about safe usage storage, and be familiar with all the drug-specific product information. That's it.
Almost done. We're going to go over the questions and the answers. So pull out your forms. We'll go over this, then we're going to take a break. I encourage you to turn your forms in during the break, and then those who want to come back for discussion can do so. I'll leave it at that. Okay. Amongst the risk factors contained in screening tools for predicting aberrant drug-related behavior in patients receiving opioids for chronic pain are family and personal history of substance abuse, legal problems, history of pre-adolescent sexual abuse, psychological problems, and what's the answer? Correct. We're going to fly through these. Which of the following is the most important to consider when determining a starting dosage of an extended-release, long-acting opioid? A 55-year-old man who is being treated for chronic low back pain after undergoing laminectomy comes for the follow-up evaluation. A trial of oxycodone extended-release therapy is planned. Completion of which of the following is the most appropriate step before initiating the therapy? All right. A 63-year-old woman with a history of spinal stenosis and peripheral neuropathy secondary to breast cancer chemotherapy comes in for evaluation because of increasing severe low back pain. She reports the pain started 2 weeks ago after doing yard work. That's why I don't do yard work. She underwent chemotherapy 12 years ago. Medication includes an opioid. Which of the following is the most appropriate next step? I didn't hear it. E, all of the above? No. All right. Use of ER and long-acting opioids in pediatric patients under the age of 18 deserves special consideration because, all right. A 59-year-old with long-standing hypertension and stage 3 chronic kidney disease continues treatment with DMARDs for rheumatoid arthritis. Recently, she has exhibited increasing pain and further functional decline, likely due to the progression of the rheumatoid arthritis and the osteoarthritis of the hips, knees, and feet. She is determined to remain a functional and possible participant in aquatic therapy and yoga classes. Which of the following pharmaceutical option is best next step for addressing this patient's pain? So, the answer, according to, it would be that they did not think that acetaminophen would be enough to manage this pain. I think this is their way of saying is hey, we're not discouraging the use of opioids in the appropriate patients. The acetamin what? Oh, okay, and the dosage, yeah. An inappropriate method to dispose of unused opioid medication is, I hate this question, by the way. D. Also, we're discouraging flushing it down the toilet. And then, of course, the pharmacies you return it to have to have a disposal function. The most important reason patients should be considered to never break, cut, chew, crush long-acting opioid tablets or cut or tear patches is because to avoid inadvertent overdose and death, patients should be counseled to avoid co-administration of extended-release long-acting opioids with which of the following? True. I agree. Which of the following extended-release long-acting opioids is most likely to induce a peak respiratory depression that occurs later and persists longer than the analgesic effect? When using equal analgesic table to rotate opioids other than methadone, an important step to account for an incomplete cross-tolerance amongst mu receptors opioids is a 72-year-old grandfather with severe persistent abdominal pain from colon cancer has been taken from immediate release opioid every 4 hours around the clock. He and his wife care for 2 young children, and he states that he can no longer help with their care due to his increasing pain levels. He wants to increase the dose of his medication and asks what else he might be able to do to control his pain. Which of the following supports the addition of extended-release long-acting opioids? What? I didn't hear it. Okay. Sorry, I got bad hearing. A 67-year-old female with severe knee osteoarthritis has recently been converted from an immediate-release opioid to an extended-release opioid for pain control. She has chronic obstructive pulmonary disease that has made her a poor candidate for surgery. In addition to extended release opioids, which is the second prescription that is most appropriate to dispense to her? A positive result of hydromorphine in a urine drug toxicology test for patient prescribed morphine can be interpreted as correct. Now, if they took heroin a couple days ago, it would also show up, but if they took it a month ago, it would not. That's it. So turn your papers in, and anybody that wants to have a discussion or have any questions of the experts, you're welcome to come back. We'll move to the discussion section after the break.